a huge adjustment for me, as you can imagine. But we have moved forward and continue our education, our KSAC, SERPA program, all through distant learning, distant teaching. I had no idea on March 12th, when I left the office, I wouldn't be returning for several months, and we were shut down. The light at the end of this tunnel is that things, as Walter said, are getting better. It is looking cheerier, and I can't wait to return to our beautiful office at 250 Bryant Avenue and welcome all of you to visit me there when we do get back in-house. I want to mention that we're having holding a virtual town hall. Maybe, actually it may not be virtual on July 9th. We haven't decided yet, depending on state regulations. And we will be having many announcements about it, and it'll be a very exciting topic. PTSD, communities in trauma. And the Commissioner of Mental Health was part of our panel, along with Dr. Harris Straightner, Dr. Alex Straightner, Dr. Nick Pace, Louis LeBoy, Connie Pacheco. So we have a lot of exciting plans going forward. Our school is growing. And again, I am so grateful to each of you who wants to learn more about a relatively new method, which is harm reduction. Walter covered so much of what I need to say, so I don't want to be repetitious, but I have such deep gratitude to our presenting sponsors. We were supposed to have our dinner the end of April, and that changed all of my fundraising for the season. And when I mentioned our need, call it fund a need, Natasha stepped right up. She's a board member, the Silver Bell Coaching, and the Capelli organization. Corinne Perry is on our board representing Louis Capelli, who's a cousin, and Peter Palazzo. And they decided to help us now to be sure that we are able to maintain our work that is so needed in the county. And we know moving forward will be more important than ever. Just 2 nights ago, I spent several hours working with a situation, actually from the entire day, somebody suffering severe anxiety, non-functional, after having had COVID. Not necessarily substance abuse, but a mental illness situation, and we have that person referred to treatment for the problem. Our gold sponsor, Sydney Weiss, a new board member, has been so generous to support us, and thank you for all of your enthusiasm and wishing to become an active part of our mission here. Laura Smith, another board member, is with Seasons of Malibu, and they have accepted to be a silver sponsor. And Intercare, located in Hawthorne in New York City, is an exhibitor. It is an honor to have Trish Guy with us this morning, who is the General Counsel for the New York State Office of Addiction Services and Supports. And she will speak on evolving practices, strategies, and flexibilities in the Oasis system of care. I've had several conversations with Tricia, and it's interesting to hear what's really going on in Albany. I'm looking forward to updates because I know that we are anxious to get back into our classroom and cannot do it until not only the state, but Oasis permits it as well. And we do have the space for social distancing, thank goodness. Very flexible space. Our wonderful board member, John Hamilton, whom I've known for several years, accepted in a moment's notice, just when I first called him, he said absolutely he would do this conference, and he wanted to speak on harm reduction. Of course, my generation, sobriety was abstinence. That's how I got there the hard way, I guess. So it's a lot of new information, new adjustments to how we're helping everyone in a day that addiction is I would say more prevalent than ever. John, I don't know how to thank you for always being with us. You have been a speaker at so many of our conferences, and you certainly are a profound one at that. John is the CEO of Liberations Program in Fairfield County, Connecticut. Thank you, Walter, again, for stepping up and taking on the MC role. As it would happen, my Zoom is working today. Yeah. All week long it failed. We were afraid that I would get into difficulty today. And Walter was so kind to say he would MC. To Laura Ramsey, who's helping us with development, and Robert Sanders, our event planner. Thank you. You're relatively new with us, but certainly you are as seasoned as anyone can be, and a blessing to our organization. My assistant, Linda James. Yes, we work very hard and it's more difficult from a distance, there's no question. And she and my dearest partnering, I'll call it in crime, and I joke around, Dennis Andrews, our board president and director of the school, have been the gophers to the office, picking things up and dropping them literally at my home in the garage. I cannot have anyone in the house yet. So we have a teamwork that is seamless, flawless, full of love, full of caring. And we know with all of those ingredients, there's only one answer. That answer is success. But our success depends on each one of you. Each one of you who attends our conferences, our events, and supports us with sponsorships. I have a plan underway for a luncheon in the fall. Hopefully it will be in person on November 5th. With the help of God, we will all stay healthy and safe, and that's my only prayer in the morning, and my prayer at night is a prayer of gratitude, that everyone I know should be healthy, and those of you who have suffered the COVID, as some of my teachers have, our instructors, or if any of you have lost any family members, my deepest and heartfelt sympathy. It is a horrific time to lose someone and not having been able to say goodbye. But as we move forward, there is another pandemic, as they are sharing constantly on the news, and it is mental health, substance abuse, suicide, overdosing. Thank you, everyone. It is delightful to be with you, and I wish you all every blessing today and always.
Thank you, Joan. That was great. Great introduction, of course, heartfelt, and as always, you connect so well with an audience, and this one in particular at this important time. So thank you. So next up, what we'd like to do is just show you a brief message from one of our presenting sponsors, the Capelli Group, and their Director of Marketing, Corinne Perry.
Walter, can you please make me the host?
Not on this. Yes, there we go. I'm sorry. There you go, Laura.
Okay, thank you.
You're more than welcome. We're seeing your screen. says Zoom join a meeting.
Did the video come through?
Not at this point.
Try again.
Okay. We'll be right with everyone.
Richard? No, I bought it. You have to make it at home.
So, Laura, if we could move on then. And sorry for the technical difficulties, everyone.
Oh, it says I'm screen sharing. Okay.
Yeah.
No.
On this end, so if you could hand me back the host. Okay.
Everyone.
Laura, you have to give that back to me.
Oh,
Okay. All right, so sorry for that. Staff, we were going to play a great video from the Capelli Group. At this point, yeah, we do again want to thank them for their sponsorship and being such good friends over the years to NCADB Westchester.
And Walter, maybe we can try and cue it up later in the program. If we can.
That's a
Try and
good
do that,
idea,
okay?
Robert. Absolutely. So next up, I'd like to introduce Natasha Silverbell. Natasha is the founder and president of Silverbell Coaching, and she's going to share a few words on education and coaching in a harm reduction world. Natasha is a CARC recovery coach and recovery coach trainer through CCAR and OASIS. She has received training as a life coach through the Ben Dean PhD Mentor Coach Program. She's also a member of the International Coaching Federation. Natasha helps clients find and realize their authentic self through increased tenderness and laser-sharp introspection. She uses her own life experiences when appropriate to help her clients move through their fears and achieve desired goals. Natasha has faced eating disorders and substance abuse while working with top designers. She had her first son at 27, and during her pregnancy, to protect her unborn child, she overcame her eating disorder and substance abuse. This initiated her road to recovery. She's since delivered 2 more healthy children, and then the desire to drink and use grew again. Finally, in August of 2008, she completely surrendered, and which by her definition means she moved to the winning side. Now she has lasting sobriety and can be of service to others because it is for herself. She says, "I'm not ashamed, I survived." Natasha is the mother of 3 amazing children, Samuel, Benjamin, and Sarah. She's an active philanthropist, loves practicing yoga, and is a front row regular at her spin class. So please join me in welcoming Natasha Silverbell.
Thank you, Walter. It's a pleasure to be here. I apologize, that bio is a bit dated because there is no such thing as a spin class these days, and I want to thank everyone for joining. By the grace of God, my company has grown, and this year will be 10 years in the industry, and what our services provide is exactly what this time would need: connection. And we believe that although abstinence being the goal of harm reduction, there's always a different pathway to achieve those desired goals. So reaching kind of across the invisible force field and going into someone's home and or creating a pathway so that the client can get to the treatment team and even get into a therapist's office is oftentimes we're the front line. And so our company, again, as I said, will have 10 years this January. And our excellent coaching has been such a gift for me to work with the coaches. I have asked one of our top coaches, Will Vogt, to come on and speak about what exactly it is that we do, because he has such personal experience in doing it. And as my bio mentioned, I've been home parenting my children as my company has grown. So it really is because of connection, which we all know is the opposite of addiction. And Will, if you could please speak and share about your experience in working as a recovery coach in the industry. Thank you.
Thank you, Natasha, and thank you to Joan and Walter, Linda, and the rest of the NCADD board, staff, faculty, volunteers for helping to put this virtual conference on this morning. And first and foremost, I'm hoping that everyone is safe and healthy this morning. Everybody does look great. We all look really great on Zoom, don't we? My name is Will Vogt, and I am one of the many coaches that are in the Silver Bell coaching arsenal of change agents that Natasha has amassed over the years, a very eclectic group of individuals and a team of educated and informed members of recovery that Natasha has put together to help people on their recovery journey. I've worked with Natasha for 5 years. I'm a person in recovery myself, and simply put, Natasha's principles and philosophy, while both powerful and simple, are very much in alignment with not only all of the elements of harm reduction, but also with the work that's done here at NCADD. Awareness, perspective, action, acceptance, and gratitude are the 5 key foundational points of what Natasha empowers us, me as coaches, to utilize in the field and in this ever-changing climate that we're dealing with right now. Now more than ever, education is important. And I was thinking about what Natasha has built, and the coaching helps individuals, people who are in recovery or struggling to get into recovery, people who are in acceptance or in denial. It helps not only the recovery, but also the families that are affected by substance abuse create awareness through true perspective for their individual situation. Because anybody that's met anybody in recovery and in life, we know everybody's situation is different. Through a hands-on, very much concierge support, Natasha's approach provides clients with the tools needed to take the necessary action to change harmful behavior and start construction on a new road that's built on radical acceptance and a new foundation in gratitude. And as I was saying before, the importance of education and training in the field of recovery is so important. The multitude of cataclysmic events that we've come to know over the last 4 months, such as COVID and the strides and outcry in social change and justice that we're witnessing on a daily basis, not only profound, but long overdue. And Natasha at Silver Bell Coaching, one of the things that she does is she encourages the coaches to always be teachable, but stresses the importance of education in a way that even during a global pandemic, we are apt and able to adapt to what's going on, because the needs and the pain and the addiction and the struggles don't stop just because the nature of the world and the things that we've come to know as a constant are changing. They don't, and we've had to use this technology, as in Zoom. Many of our coaches are still in the field, and like myself, back in the classroom. And through Natasha's tutelage and suggestion, I was able to take advantage, and I'm currently taking advantage of programs that NCADD offers for coaches who are educated. Listen, You know, I went to Goucher College and the Peabody Institute at Johns Hopkins University. I worked in the White House. I've written for television shows. I'm a father, and I'm also somebody who's 7.5 years sober. So I do consider myself to be a person who is educated. However, you know, in recovery, you need more education. And we need people like Natasha who are cultivating young talent in recovery and also connecting them with people like Joan and NCADD to achieve a higher level of clinical training or peer advocacy here in the state of New York so that we can bring those things directly to our clients. I'm currently enrolled in a very grueling and long process, which is the CASAC clinical training that NCADD offers. They also deal with ethical considerations, motivational interviewing, peer advocacy. And these are all programs that are available to people who are already working in the industry. And if it wasn't for leaders and board members, you know, like Natasha, I mean, I've worked for many different organizations and as a sober companion, as a coach, and most importantly, as of service. And the value and the emphasis that Natasha and Silver Bell Coaching place on not only being of service in real time to families and the clients in which we support, but concurrently continuing our education so that we're able to, as coaches, provide the best, most up-to-date, knowledgeable service for them is really why I work with Silver Bell Coaching and why I work for Natasha, because we work in team consultation, you know, and it as you can see over the last few months, you know, it does take a team effort, regardless of what the challenge is. And when we're dealing with substance abuse and we're dealing with mental health issues, recovery is a team sport. The coaches, the clinicians, the counselors, the families, and the clients. So I'm really honored and blessed to be here. I'm blessed to be not only an employee of Natasha's, but also a student here at NCADD. And you know, please feel free to you know, to reach out to either Natasha or myself in the chat if you would like more information about what we do and the services that we can offer. And with that, I will humbly say thank you so much for allowing me the ability to speak today and to sing Natasha's praises. And also, again, thank you to Joan. You look fantastic this morning. My God, I feel like you were just on the Today Show. And also,
You
Walter.
didn't see me?
Oh, I saw you. I saw you. I could see you. And also for Walter, you know, putting these types of events together are really, really challenging work. And he's been doing an extraordinary job. And the speakers that we have coming up this morning on harm reduction are absolutely worth it. So thank you very much.
Oh, you're welcome. Thank you, Will. And yeah, it's great to see everybody this morning in, you know, with everything happening in the world. It looks like everybody who registered is on and participating, which is great. And we're watching the chat as well. So at this point, and again, thank you, Will, and thank you, Natasha, for coming on this morning, you know, with your important message and, you know, taking this thing forward. Really appreciate it. At this point, I'd just like to recognize another one of our sponsors, Sydney Weiss. She also happens to be the newest member of the NCADD Westchester Board. Sydney is a highly sought after interventionist who works with families as she understands that interventions are not just events, but rather journeys. She also offers treatment placement and case management for entire families here in Westchester, from her offices in Katona and in Manhattan, and she's worked with clients from across the country. In fact, I think she mentioned over 30 states. So you can learn more about Sydney on her social media page. You can email us at or info@ncaddwestchester.org, or you can give her a call. She said 914-471-2563. Thank you very much, Sydney, for joining us this morning.
Thank you, and you're welcome. It's a pleasure to be here.
Fantastic. So, okay. So at this point, I'd like to introduce our next speaker, Tricia Shell Guy. Now, Tricia is General Counsel for the New York State Office of Addiction Services and Support. In this role, she provides legal advice, guidance, and policymaking support to the New York State OASIS Commissioner, agency executive staff, and all agency divisions. Prior to appointment as General Counsel, Ms. Shell Guy served as OASIS as Deputy Counsel for 5 years and as Associate Counsel for 5 years as well. She's also served as Senior Attorney for the New York State Office of State Controller and New York State Department of Motor Vehicles. We won't get into all the great experience we had in motor vehicles at this point. Prior to her state service, she was engaged in the private practice of law for 13 years, where she practiced in various areas of civil and criminal practice. Ms. Shell Guy has also co-authored an article on confidentiality and patient issues related to the sharing of substance abuse disorder treatment information for the Health Law Journal of the New York State Bar Association. And she's made numerous national and local presentations on issues pertaining to prevention, treatment, and recovery issues impacting New Yorkers and the state system of care. Ms. Shell Guy resides in Glenmont, New York, with her husband, 2 children, and she asked me to mention several pets. Please join me in welcoming Tricia Shell Guy.
Hi, Walter. Thank you. Can you hear me okay?
Absolutely.
Okay, great. So, yes, Walter and I talked about that, and my pets are very important to me. They ground me and keep me calm in my life, raising 2 teenagers, which are now living in my house 24/7. So thank you for inviting me to participate in this conference. I'm particularly excited to be at a conference, believe it or not, that is titled Harm Reduction, because I think that sort of was a voodoo taboo kind of world or kind of word in the OASIS history. And so I'm glad to have the opportunity to speak to all of you folks about how OASIS has evolved in its thinking. I've been here almost 12 years, maybe even 13 years, and July is my anniversary, I believe. And the changes ever since I've been here have been dramatic. I may have been a little green when I first got here, but now when I look back, it's amazing to me how we've evolved. And the time was right. And I would say it was a collective effort. It wasn't just state regulators deciding that we needed to change policies for budget reasons or other reasons. It was the field. It was the families. It was prevention. It was treatment. It was recovery. It was everybody getting together and recognizing that we needed to move the field. And in order to do that, we needed to move the regulators or drag them along. The opiate crisis provided some opportunity, I think. I hate to use that word, but to get people to listen to us at levels that they hadn't listened to us before. So, Walter, I don't know, do you want to put the PowerPoint up?
It's here we go.
Up to you.
Mm-hmm. There you go.
Great. So you're controlling it, right?
Mm-hmm. Yeah.
Great. One of the things I've learned in my years here, I am not in recovery myself. And so to some extent, I think that puts me at a disadvantage. But I have learned to listen to all of the people that I meet in the field, people in the treatment field, people in the recovery field, people in recovery themselves, families that have suffered loss. And the one thing I've learned is that recovery is different for everybody. And that's not necessarily a bad thing. What I also learned is that people need to have the tools in order to achieve recovery, and that those tools are different for everybody and really depend on many variables in an individual's life. Do they have family and other supports? Do they have the financial means, which unfortunately is true and real, and much as we would like there to be a universal health care or a mechanism. It differs depending on your financial means. And do they have the motivation? Is it time? Where are they in their journey? And so that's why I think this conversation about harm reduction is great, and I'm glad to be part of it. So if you want, you can switch slides, Walter.
Mhm. Okay.
So, like I said, harm reduction was a word when I first started here we did not utter. That was something that the AIDS Institute used, other people used. OASIS did not use the word harm reduction. OASIS still doesn't really use the word harm reduction, although I think we are far more open to it now. And a lot of our policies and a lot of the direction that we are going in is a harm reduction mode. So we use the word patient-centered care. And on this slide, I've put a few bullets in about how did we move in the direction of patient-centered care here at OASIS. And it was a long journey. It started with changing practices and then ensuring that we had the financial means to support the new practices we were asking people to do, and really changing the mindset of a lot of people who have been in this field for a very long time and have seen successes with the models they had and didn't really see the need to make changes. And people don't like change. Change is always hard. And sometimes you think, well, why play with a good thing? But we needed to recognize that there were standards of care, and we have a medical director who issues guidance and has very strong opinions and beliefs about what is good treatment. And so we really started to move in the direction of what OASIS would consider harm reduction, and that's patient-centered care. It's recognizing that abstinence, while it may be a goal for some folks, it might not be a goal yet, and it isn't a goal for everybody. And care at all levels of care in the OASIS system needs to be patient-centered. Treatment plans need to be patient-centered. Patients need to have a voice in it. Patients need to be involved. Families need to be involved to the extent that they are supportive of the patient and the patient's needs and goals, and the patient, of course, wants them involved. And so one of the earliest things that we did was really start to look at medication-assisted treatment beyond opiate treatment providers, so beyond methadone, the traditional methadone that has a stigma of its very own. We've been trying for years to destigmatize methadone maintenance, as well as other forms of treatment for opiates, buprenorphine and other injectable medications. We've slowly done that by changing things in our regulations and guidance documents, and even approvals we have with the federal government to remove stigmatizing language, to reference opiate treatment instead of methadone, to move opiate treatment into a direction where it really looks more like an outpatient type of care, not just long lines of folks getting their medication, and not really obtaining any other of the necessary treatment and supports that they need. And there's more to come on that. We continue to look at how we can make opiate treatment more accessible. We now require all providers to offer medication-assisted treatment. They can't offer methadone if they're not an opiate treatment program. That's a federal rule. We fight the federal government on that as much as we can to try and argue with them about why, or justify with them about why methadone should be treated like other medications, why physicians and others should be able to order and prescribe it for like other medications. There's always been this concern out there that methadone diversion is for some easier or more likely. I don't know that that's actually the case. I think that that's antiquated beliefs. And so recognizing medication-assisted treatment, requiring providers to offer it, not allowing providers to discharge individuals who are on medication-assisted treatment or want medication-assisted treatment was all a move in that direction. Another really significant thing that we did was add peer services to the cohort of services delivered in our system. In the outpatient world, we added peer services way back in 2011 when we changed the billing mechanisms in that system. It took a very long time for peer services to sort of have an uptick. They weren't that popular in 2011. They were an optional service. We didn't require it. And we didn't, frankly, have a lot of certified peers out there. Over time, though, as we moved into managed care with the behavioral health services, and as people started to recognize the value of peers, peer services have become far more utilized, and in fact now are a required service in all OASIS outpatient settings, and also can be used in other settings, and we hope are used in other settings. We also have something called behavioral health HCBS services, which are services that are provided to higher need individuals in both the OASIS and OMH systems. We called it HARP enrolled, for those of you who are familiar with what we did in managed care. Peer services can be offered in that arena as well. And of course, one of the most important things about being able to offer a service, not most important, but important to a provider, is that the services be reimbursable, right? It's easy to say you need to do these services, and it's easy to say that they're valuable, but to the extent that you're not getting payment for them, it's difficult to implement. And so we were the first in the state to provide a Medicaid rate for peer services back in 2011. And most recently, we enhanced that rate by 50% because we recognized that the value of these services was really great, that they were helping folks, and that people needed to be supportive of them and needed to have the necessary funding to do them. So we just recently increased those. Other things we did were add things like recovery centers, expand recovery centers. We have found great value in the use of recovery centers, add family navigators, issue standards of care, which was also very, very important in moving towards this patient-centered care and a more harm reduction model. And those standards of care recognized, as I said earlier, abstinence is a goal, not the only goal. Recognize that folks should not be discharged for using, that you need to have policies and procedures, and to the extent that there's a safety issue for that individual or for others in the program, when discharging, you know, a program is responsible to ensure that there is a handoff and that that person is safe. And then modifying our regulations, which we have been doing for the last 10 years consistently. And most recently, we issued a new Part 822 regulation, which is our outpatient regulation that covers outpatient programs and opiate treatment and outpatient rehab programs. We've been consistently removing stigmatizing language, but in that regulation that we just issued and was just published, is out there for public comment now, we really changed the approach that we took to care. We recognize that addiction is a chronic illness, is something that doesn't just end, that the idea of admissions and discharges can be complicated for folks, and that really it's more of a medical model that we should be taking if this is a chronic condition. And so we modified the regulations to remove a lot of requirements that just didn't make sense. When you go into a doctor's office, your doctor doesn't sit down with you when you come back on the 90th day and say, okay, we need to sit here and we need to modify your treatment plan. What are your goals with regard to your diabetes? That doesn't happen. What the conversation is how have you been doing? Let me take necessary tests. Let's talk about medication adherence, and notes are put into your file. That's your treatment plan. Your treatment plan is a living, breathing document. And it should be the same in a substance use disorder program, a living, breathing document where people are less focused on meeting time marks of 90 days and more focused on listening to patients and updating it in that way. Another thing that we've done in moving towards patient-centered care is really try to move our media messages in that direction. I don't know how many of you folks have seen them, but our commissioner is often on in the mornings in different regions doing television shows. We've done a lot of radio. We've done a lot of billboards. The idea is to encourage folks to seek treatment. Clearly, that's what we're offering in those messages. However, we do recognize that when folks are using, they should do so safely. They should have Narcan, and we have tried to make Narcan as available as possible. All of our programs are supposed to ensure folks have Narcan when they leave. We've made changes to the insurance laws and the Medicaid managed care plans requiring coverage of Narcan. And so we're trying to enhance the ability to access Narcan. We're trying to let folks know that if they're using, they should be safe. They shouldn't be alone. They should be aware of things like fentanyl and the dangers of fentanyl, and they should always have Narcan. And so you're going to see some more media coming out to that end recently, especially given COVID and the anecdotal indications. At least we don't have real data at this point, but definitely indications that overdoses have been on the increase because of this COVID and people being alone and sheltered, which is problematic. Can you switch to the next slide, Walter?
Of course.
I'll try to go a little faster too. I'm sorry, I could talk forever.
How's that? Good.
Perfect, thank you. And so other things we did to sort of ensure access and make sure that people can get the care when they need it. Allowing telepractice services statewide. We did that across all modalities. So in the mental health world, in the addiction world, in physical health, we added telepractice services and provided payment mechanisms. Commercial plans must cover it. Medicaid must cover it. We modified our insurance laws related to things like prior authorization, concurrent review, and medication access. We found that you can have insurance, and that's great, especially on the commercial side. But if the plans have mechanisms in place, processes and things like fail first and extensive timeframes behind prior authorization, people aren't going to get the care they need. They need to get the care when they walk in the door. And so all of these insurance law modifications that we've put in place and put into statute are our attempt to get people into care first and make sure that there aren't barriers in the insurance world. We also added similar protections in the Medicaid managed care contracts, things like no prior authorization for outpatient services, things like ensuring of adequate networks, requiring them to cover peer services, all the things I'm talking about. We also have the CHAMP program, which has been around now for a few years. This is our New York State Ombudsman for mental health and addiction services. Stephanie Campbell is the project director on that, also a person in recovery, an amazing, wonderful woman. This is a statewide program, and it's devoted exclusively to increasing access and ensuring that folks who have commercial insurance and other types of insurance have access, and that payment is made by plans when it should be. And also enforcing parity. I won't go into too much detail on that, but we are taking robust actions now with our partners at the Department of Health and Department of Financial Services to make sure that plans are complying with parity. And new regulations are going to be issued very soon by both DFS and DOH on parity compliance. And our plan is also to have a public-facing website detailing plans compliance with the parity rules. Okay, COVID. So COVID provided an opportunity, I think, for all of us to learn a great deal. And so in the OASIS system, what was our COVID experience? So it required us to make very, very fast changes. You could switch, thank you. Very, very fast changes to across the board, across the system. Changes to the way folks were admitted to inpatient and residential programs. We needed to accommodate the fact that hospital detoxes needed to temporarily shut those beds down, use them for COVID folks. And so that left our system to come to the rescue of those folks. So we had to do that, and we had to do it quickly. And our folks were able to do it and able to do it well, and are still doing it, even as hospitals are slowly opening up. Telepractice, I think this is the most significant change we saw. Telepractice, we essentially mandated every outpatient program start doing telepractice. And with changes to a lot of the federal rules and relaxations and waivers on the state rules, we were able to do telephonic services and get reimbursement. Peers were able to do telepractice, which was an amazing thing, still is an amazing, amazing thing. Buprenorphine inductions were permitted. Prevention services are being done by telepractice and being done successfully. And cost sharing. So deductibles and copays for commercial insurance were waived for telepractice services during COVID. We've learned a lot. We are currently trying to make many of the things that we are doing during COVID permanent. Telephonic services, peer services, buprenorphine inductions to the extent we could get the federal government to agree. And so I think you're going to see a lot of changes with telepractice. OTP patients, opiate treatment program patients, we had to act quickly. We couldn't have thousands or hundreds, depending on the program, of patients lining up outside of an opiate treatment program waiting for their medication. It didn't meet social distancing requirements and was ripe for the spread of COVID. The OTP programs and OASIS staff took immediate, swift action to change how OTP services were delivered. They expanded take-home. The federal government was participating in that and allowing it. And so people were now taking home 7, 14, and even 28-day doses. We added billing to accommodate the ability to take home because our current billing structure didn't do that. It wouldn't pay a methadone provider what they needed to get paid to deliver extensive take home. And as you probably all heard in the news, we in the city of New York worked to do home deliveries for people who were in isolation, hotels or homebound. And that's also something that we're seeking to continue. Okay, next. I just wanted to touch quickly also on OASIS operations during the experience. So OASIS never shut down. We were always open. Our Albany office was open with folks in it. Our regional offices were open with staffing in it. Our New York City office did have to shut down. But we were always here. We were always open. We continue to be open. And so to the extent that you need to get in touch with folks, we are here. Our ATCs remained open and also really needed to accommodate folks, sometimes at higher levels than they were used to. As I said, many inpatient programs needed to do that. Learning and development had some changes, right? We moved swiftly to an online learning platform exclusively, and needed to recognize that that some folks weren't going to be able to get the learning hours that they needed in time consistent with credentialing requirements. And so credentialing and certification has all been extended. We don't have a final date on when credentialing and certification is going to extend. The emergency ends September 7th, technically, according to the governor's first executive order. We are thinking it will be at least 90 days after the end of the emergency that we will extend needed credentials so that folks are able to get the learning and development that they need. I don't anticipate learning and development going live and in classroom until phase 4. Education is in phase 4. Nobody is in phase 4 yet. And so I think when we hit phase 4, in-person education will be permitted. However, there will still be restrictions on social distancing, wearing a face mask, and size, potentially maybe no more than 25, depending on your space. Program review and other audits were all suspended, have not started yet, and we're talking internally about what does that look like. Regional office had to shift quickly to ensure that they could continue to assess health and safety of patients, but do so from a distance. And they have been on the ground, available essentially 24/7 to assist providers with their questions. So I know I went over my time. I apologize. On the next slide, I provided some email addresses for folks who have questions. There's my email address. Anybody is welcome to email me at any time. So I gave you essentially the addresses for legal, training, credentialing of CASACs and peers, certification. If you have questions related to treatment, managed care, or payment, those go to PICM, patient advocacy, and that ombudsman program. Happy to take questions if anyone has any, and thank you so much.
Yeah, if anybody has, would like to post anything on chat as a question, but in the meantime, certainly want to say thank you, Tricia. That was a great presentation. And as I mentioned and posted on the chat, we would be happy to send out a copy of the presentation to anyone that needs it. Just info@ncaddwestchester.org, and we'll get that to you. So that'll be I think, a nice resource at that, okay? So if there aren't any questions, we'll just say again, thank you so much, Tricia. That was fantastic. Really, really enjoyed
You're
it.
welcome.
Thank you so
Thank you for having me. I hope to meet you all in person someday.
much. All right, so let me just come out of here. And all right, so next up, we're going to have a presentation by John Hamilton. So let me just bring that up. And
I try to share the screen and do it, Walter, or what do you think?
probably gonna do it on my end. That's
Okay.
okay.
Sure, that's fine.
You wouldn't mind.
Not a problem.
And a good morning, John. So I'd like to introduce John Hamilton. John's the Chief Executive Officer and President of Liberation Programs, which he rejoined in 2018, having served as the agency's Vice President of Clinical Services and Senior Vice President from 1996 to 2006. He's a nationally recognized expert in the field of addiction treatment and prevention, and he brings 3 decades of experience to his role as President and CEO. John chairs the advisory board for the Connecticut Department of Mental Health and Addiction Services and serves on the Governor's Alcohol and Drug Policy Council. Previously, John was the Chief Clinical Outreach Officer at Mountainside Treatment Center, a nationally acclaimed drug rehab center with locations in New York and Connecticut. He served as a Chief Executive Officer of Recovery Network of Programs, a nonprofit behavioral health agency serving the greater Bridgeport community. John's past chair of the Dissemination Committee for the National Institute for Drug Abuse, Clinical Trials Network, past chair of the Community Treatment Providers Caucus, past president of the New Association of Drug Court Professionals, and co-founder of the Greenwich Fathers Forum. John's consulted for NIDA and the Substance Abuse and Mental Health Service Administration as well. In 2013, he was the recipient of the American Association for the Treatment of Opioid Dependence Niswander Dole Award for his contributions to the field of addiction treatment. John's also a proud Marist College graduate, which we found when we spoke. And I'd like to, again, please have you join me in welcoming John to our program this morning.
Walter. And I want to thank my colleagues, and everyone pretty much echoed my theme of what I'm going to say today. I think Natasha started out with saying what's most important here is that harm reduction is about connection. Harm reduction is really something that was mentioned by Tricia, and I think is shared in the field, that had a lot of confusion for years, many, many years. And I'd like to say that now is the time that we have to recognize that harm reduction will save lives. I'm also on CCAR's board of directors, and Connecticut Community of Addiction Recovery has a national conference every year called the Multiple Pathways of Recovery. So we know there are multiple pathways to recovery, and I want to point out that harm reduction is one of those pathways to recovery. Harm reduction is innovative engagement and connection. As Natasha put it, it's all about connection at the end of the day. Our field actually had been really bifurcated and splintered early on. Years ago, there was the drug treatment field and the alcohol treatment field. The drug treatment field was made up many years ago, 30 years ago, of therapeutic communities. In therapeutic communities, there was drinking privileges, and I worked in one of those therapeutic communities. So looking back now, it's like, what were we thinking? Well, we were meeting people where they were. Even the name of my program was called End Dependency on Narcotics. It wasn't focused on drinking. So there were people that actually left with drinking privileges, and for most, they crashed and burned. For others, they're still in recovery for opiate addiction and not drinking today. The alcohol field, as people know, was an abstinence-based model. Joan pointed that out in her opening remarks. Joan also recognizes that we have this opiate epidemic. And now the opiate epidemic is a fentanyl epidemic. In Connecticut last year, we just saw the release of the medical examiner's report of deaths. 86% of the deaths last year were fentanyl related. And now we're seeing this xylazine. I don't know if people are seeing that yet, but that's actually an animal tranquilizer that's being mixed in with fentanyl. And again, more lethal, much more lethal than what we've seen in heroin overdoses. SAMHSA, sadly, even with all the efforts of changing policy and innovative engagement, is projecting in the next 5 years that overdoses in the country will exceed 100,000 per year. So we have a lot of work to do. So that's my opening pitch on harm reduction. There are multiple pathways to recovery. Death is not one of them. We have to keep people alive, and that's what harm reduction is all about. So why do people take drugs? Walter, I think we got to click this twice. This comes from a NIDA slide. And the NIDA, basically, the National Institute of Drug Abuse, says that people do drugs for 2 reasons from a brain chemistry perspective: to feel good and to feel better. What we know is those that generally go through life to feel good and engage and connect with others and have shared experience, they're not the people we're seeing as recovery coaches and treatment programs in private practice. We're seeing the people that are doing it to feel better. To lessen anxiety, worry, trauma, depression, hopelessness. It's about disconnection to community, disconnection to self, disconnection to feelings. Next, Walter. Just again, give people perspective. People may have seen this DEA slide, but that's a 2-inch, a ruler with 2 inches next to it. That's the lethal amount of heroin, the lethal amount of fentanyl, and the lethal amount of carfentanil, 2 micrograms, that people will die from. And right now in the streets, people can get several bags of what they think is heroin or fentanyl, and one could actually be a lethal bag because there are no controls. Next slide. Also want to point out, people are not just going into, starting with Oxycontin or starting with heroin and getting to fentanyl. If somebody misuses alcohol, they're 2 times more likely, twice as likely to actually get involved in heroin than the general population. If they're misusing marijuana, it's 3 times more likely. If they're misusing cocaine, it's 15 times more likely. And if they're misusing opiate analgesics, they're 40 times more likely of getting involved in heroin. Next slide. So what is harm reduction? I really want to point out that harm reduction is a mindset. It really is an approach for engagement. It's a perspective and a set of practical strategies to reduce the negative consequences of drug use, incorporating a spectrum of strategies for safer use to abstinence, not always having abstinence as a goal. For some people, you have to ask that person what success and quality of life is for them. And it may be going from, if somebody's going from committing felonies to misdemeanors, that's a success story in my eyes. It's all about meeting the person where they are at. And just to point out, because I think this was brought out by Tricia before, to be a little more controversial about harm reduction, MAT is not harm reduction. Medication-assisted treatment and recovery is the gold standard for opiate addiction. In fact, what we know is if a person is not on one of the 3 FDA medications, methadone, buprenorphine, or injectable naltrexone, in their first year of recovery, they will have a 90% chance of relapse. And what we also don't know is who that 1 in 10 is that doesn't require medication-assisted treatment and recovery to quiet their brain and has enough, as we would call it, recovery capital to be able to not have the need for medication-assisted treatment. So ultimately, we do believe we need to focus on helping people with skills over pills, as they say, but you have to quiet the brain till the miracle happens. The person has to stay engaged, and that's where medication-assisted treatment has to be looked at as the gold standard. And as was shared by my colleagues earlier, the other gold standard is engagement and connection. The goal of a first meeting with an individual is to have a second meeting. It's that simple. Okay, so our experience has taught us that the importance of the moment when attempting to reach out. Meeting, the lifeblood of harm reduction, as you've heard, and people say it all the time, meeting people where they're at. Grammatically, it's meeting people where they are, but I like meeting people where they're at because that's what people know on a street level is necessary. And as I said, there was the therapeutic community crew, there was the abstinence crew, and what was mentioned earlier by one of my colleagues, there's the HIV Ryan White crew of public health that are way ahead, probably 10 years ahead of where we are on a street level of harm reduction strategies. Next. So some of the few basic principles of harm reduction that, again, is not without controversy is recognizing that abstinence is one of many possible goals, not an end goal for everyone. Again, you're meeting people where they're at without your agenda. Meet people where they are means you don't have an agenda or a bias. And you can look at the fact that drug-related harm can't be an assumption that drugs fit a need for people. It often fits their need of pain. You want to get into literature on harm reduction that I think is very, very important. Read Gabor Mate in The Realm of Hungry Ghosts. He talks about all addiction is rooted in trauma and pain, and that the goal of recovery is the ability to stay present. The drug users are more than their drug use. So it operationalizes treating people with dignity and respect. And I spent a lot of time in the National Institute of Drug Abuse working with Bill Miller and motivational engagement. It really is about operationalizing that engagement. We also know in the research, confrontation drives people out of treatment and recovery. Next. Here it is on a continuum. I don't know if you can blow this up, but it's, Walter, but it looks like people can see it. It's just recognizing there is a full continuum of substance use from none to chaotic. And those different areas continuum require different interventions and perhaps are involved in different level of motivations and engagement with people. It's going to catch up now. It's better. It's a bigger screen. There you go. Thank you, Walter. And now you can see that it's a full continuum. And here is, again, where we are not aligned in our treatment system. Oftentimes, we're required to give people a diagnosis for reimbursement. That ties our hands for people that may be, as they call it, sober curious and maybe just still using. That doesn't fit on the continuum oftentimes of the work we do. Or I think what becomes really concerning is to check with your agency, if you're working for an agency or you have your own company, what are your policies and guidelines regarding allowing people to continue to use? Because sadly, in some treatment systems, we throw people out and discharge them for basically showing the symptoms of their addiction and their disease coming in. And then they use, and then we throw them out instead of finding out what we can do to engage them even more. Next. So harm reduction is designed and promotes a public health intervention to use to minimize the harmful effects of drug use. Next slide. It focuses on changing behavior, especially when related to overdose prevention, treatment. It involves housing, employment, parenting, other relationships. It's looking at all of what's going on. I mean, in this day and age now, everyone's looking at social determinants and social justice. I think people need to see that harm reduction fits well with social justice initiatives. So the principles are users' decisions to use is accepted. This could be tough for some clinicians or recovery coaches to actually allow that without trying to bring them somewhere else. User is treated with integrity. The user is expected to take responsibility for their own behavior. The reduced harm is not necessarily reducing consumption. It may be just using in a safer manner, and there's no predetermined outcomes. Another big piece with harm reduction is about language. People have heard on one end of the continuum of the harm reduction movement, and it actually started in Vancouver with Liz Evans, who I think did some work in New York recently. It's you have safe injection sites, and safe injection sites are not without controversy because people are in a public consumption place and using. But with regards to language, they're now moving that dialogue and not calling them safe injection sites anymore, but instead they're calling them what they are: overdose prevention sites. Because Robert Heimer from the School of Epidemiology at Yale did a study in Connecticut that suggests that if you are in active recovery for an opiate addiction in Connecticut, you are 3 times more likely of dying from a heroin overdose than if you're still doing heroin today. It seems pretty shocking, right? But when you think about it, if you are in active recovery and you do end up having a lapse and a relapse, you're more likely, because of the shame around your relapse and letting people down or letting yourself down, you're likely to be doing that in isolation without anyone around you that has Narcan that's going to revive you and keep you alive. So that's really important to mention. Somebody even on the chat said that makes sense. Thank you. Okay, next slide. So here's that again, we got to dig deep into this. The user's decision to use is accepted. We have to be able to meet them where they're at without our agenda means, you know, if we're walking away and we're frustrated because they're still using, that's the need for supervision. That's our work. We need to keep that out of the room, remotely or in real time with that individual we're working with. Harm reduction acknowledges the drug user's decision to use as a fact and not as an issue or a problem in and of itself. Harm reduction approaches presume that for the present, the user is going to continue his use or her use and neither approves nor disapproves of the user's decision to do that. You can't be in a position of approval or disapproval, or again, it goes back to, if you want to have a second session or meeting with an individual, as we call them in Connecticut, recoveries, you have to engage them in the first session and treat them with dignity, respect, and no judgment, and give them something of value and be a good listener, or they're not likely to come back. Any positive change. That's another focus. That's that glimmer of hope. I think at the end of the day, we're in the business of hope. And given the harm reduction emphasis as a process of change with no predefined outcomes, harm reduction programs work with drug users towards any positive change. This could mean anything. A change in method of use from injection to oral use, a change in frequency. Maybe they're going to use from daily or once a day, or even a change in reasons from dealing with crisis to having fun. All that is progress. Years ago, there was a controversial book by Norman Zinberg called Drug Set and Setting that actually spoke of the fact that there is a cohort of individuals that can socially use heroin. The problem is if they broke down any of those rituals around their use, they would immediately succumb to a full-blown addiction. Next. What are the outcomes? They're phenomenal outcomes in harm reduction. It's one of the most effective programs that we can have. It enhances public safety. And here is some of the myths. Some people believe harm reduction increases drug use. There is no data. There is no studies that show that harm reduction programs will increase drug use. Harm reduction programs serve as a hub to connect substance users to the treatment community and bridge that gap, which oftentimes isn't bridged between public health and particularly public safety and the traditional treatment programs. And there is a lot of cost-benefit studies showing the economic evaluation of these will save taxpayers money. So some individuals are not so concerned about the individual still using, but to think about the impact on the community. And so depending on where the person's coming from, it saves lives and it saves money. Next. So the elements of a harm reduction program is you have to have the stakeholder, the resource in front of you, as even CCAR talks about in recovery coaching, is your client, is that person in recovery, that person that's still using. User involvement is key. Any positive change, as that person defines it, is what you're paying attention to. Supportive agency policy, go back, as I said, to your respective agencies, and we have, the state with Tricia talking about how they've changed policies to become more harm reduction friendly. Are you, in fact, able to work with people that are still using without restrictive policies to send people out? And the same thing with private practice. Somebody's bringing that out in the chat. That's very, very important. And in fact, I've worked in private practice for 30 years, and most of the work that I've done in private practice has been harm reduction, and most of the work I've done in my traditional treatment programs have been abstinence-based because some of the restrictions and the policies and the funding that we've gotten over the years. So that has started to change so we can serve more people. So the efficacy and outcomes from the syringe exchange program, people are familiar with that, has one of the most effective tools to reduce HIV and hepatitis C for those that inject drugs in cities across the nation. It has actually been so important as a harm reduction strategy, and probably something that most people are familiar with. But in traditional programs, how many traditional programs do syringe exchange? My agency does, but there are other agencies that I know of that would not support that because of policy, and sometimes, sadly, even because of philosophies. So I like the fact that OASIS is starting to mandate more harm reduction, as Nicole is just sharing on the chat. So that's great news. Next. So syringe access programs are the most effective evidence-based HIV and hepatitis C prevention tool, period. And that's the key. And there's an example of where it is. Next. Here's another tool in harm reduction that, again, I'm wondering people on this call, on the Zoom, have ever even seen. This are fentanyl testing strips. Are you giving out fentanyl testing strips? Since, as I mentioned in Connecticut, I'm sure it's no different in New York, we're seeing a significant rise in the number of fentanyl overdoses. So if somebody's still out there on the streets using, can you give them a test strip so they know that what they're taking is not the heroin that they think they've gotten, but actually fentanyl that will allow for a less likelihood to take as much and die of an overdose. So these fentanyl strips are available. I think they're like $1 a strip, but they really, again, for people that are still using, can be a lifeline and save lives. Next. What are the high risk factors for an overdose? We can click it again. I'll go back one more. Skip the slide, Walter. Yeah. Can we go back one more? A loss of tolerance. People that, for instance, have no experience with detox can go into detox for the first time, and they can come out using the same amount of bags that they did when they come in, and they die because they've lost their tolerance. People coming out of the criminal justice system are 72 times greater likelihood of dying of a drug overdose. An unbelievable risk of people who have not been using and have lost their tolerance that could really be in trouble when they come out. This has to be educated for people that are still on the streets, literally. In New Haven, we educated the police department, and they were giving overdose prevention gifts out because oftentimes they took people's drugs and their works away, and then they were left to actually maybe have to buy and purchase something that they weren't familiar with, and it would leave them at more risk. So that's a point of intervention that can save lives with law enforcement that we're trying to promote. And that's something that, again, if somebody's leaving detox and is not planning on connecting to care, the greatest likelihood if somebody leaves detox and doesn't connect to the next level of care is relapse. We know that. And they're at the greatest risk of overdose because of that reduced tolerance. Mixing other drugs, really, I told you about this, the animal tranquilizer, xylazine, that's what we're seeing now. In Connecticut last year, 30% of all overdoses had traces of benzodiazepines in the system. Benzos are being overshadowed by this opiate epidemic, but we actually have been tracking in the prescription drug monitoring the level of the number of drug overdoses and even the purchasing from prescription drug monitoring of controlled drugs. And the top 5 drugs, only OxyContin, what made the list, the other 4 were benzodiazepines. And people are using them for anxiety, people are using them to manage their withdrawal and managing their addiction and sometimes their recovery, but it has a synergistic effect and can kill people if they're also using opiates. So people need to be educated about benzodiazepine use, as well as 30% now of the overdoses that we're seeing also had traces of cocaine in them. So David Musto, who was an addiction historian from Yale years ago, had always said that after an opiate epidemic in this country, it was always followed by a stimulant epidemic. So this is one more thing we have to be aware of because it really is something that we're starting to see on the rise. And alcohol is also in 20% of the overdoses in a person's system. Using alone, again, becomes a significant risk factor for individuals. And we talk about public consumption sites. And I had great help in this presentation with one of the cutting edge harm reductionists in Connecticut. His name is Mark Jenkins. and he talks about public injection sites to city officials in Hartford, is the city town hall, is the libraries, are the Starbucks, are the Dunkin' Donuts. These are the public consumption sites that are already existing that are really informal public consumption sites that we can do a better job and save more lives if we provided more of a dignified space for people and somebody there to bring them back to life if they did overdose. And obviously the variety of strength of street drugs with fentanyl in the system is just so unregulated. It's scary. So this is why, as Natasha just said in the chat, connection is so important. Connection is the gold standard. People would say from a therapeutic standpoint, it's a therapeutic alliance that you have, but it's really about connection. And if you've looked at the work that Scott Miller has done over the years on therapeutic alliance, by the way, therapeutic alliance has nothing to do with your credentials. Therapeutic alliance has to do with your client or the person you're working with's ability to see you, treat them with dignity, respect, and compassion and empathy. In fact, Scott Miller did dug a little deeper on therapeutic alliance, and he found out that one of the key variables to engagement of therapeutic alignment is your client's perception of your health, which makes sense. Why would a client listen to anything that I have to say if I just seem like I'm a hot mess and I don't have my act together, right? So one of your greatest gifts to the people that you serve is your hopefulness, your joy, your mood regulation, your self-regulation, your ability to show that you have a life that might be attractive to somebody else, and you have something that somebody else might want something of, right? And then, so next slide, Walter. Say twist up.
Just a moment.
That's Greater Hartford Harm Reduction Coalition. That's my friend and colleague, Mark Jenkins. So somebody earlier in the chat said, I want some specifics. Here are some specifics. These are very different levels of intervention that are all harm reduction. You have the crisis intervention with mental health, first aid, depression screening, pain assessments and screening, and brief intervention and referral to treatment. Wound care, giving people something they need. We have a van and we go out in the community, and one of the key pieces that people could benefit from is wound care, vein care, soft tissue care, safer injection strategies, very concrete, specific health strategies that's going to allow somebody to stay healthy and stay alive. Hepatitis C and HIV testing, counseling, referral to treatments, prevention, and education are all part of harm reduction strategies. Opiate overdose, my colleague Tricia mentioned this earlier. People are hopefully very familiar with the need for Narcan. And in fact, going back to detox, if somebody's leaving detox and is not connecting to care, and as we say that the greatest likelihood then is to relapse or use detox again, everyone should leave with Narcan. And that in itself is an intervention of us letting them know, this is what's more likely to happen when you leave. We just want to keep you alive so you can come back again. And working with families to give them Narcan education becomes so important as well. Health insurance, enrolling people, getting them on benefits, that's key. We have entitlement specialists because we really need to get people on benefits so they can take care of their health. Care coordination and helping them challenge some of those social determinants, barriers to treatment, individual recovery plans, transportation. These are all services that you can provide for individuals without any requirement of the person having to be completely abstinent. And then there's medical case management, connecting people to treatment, keeping them engaged when in treatment. I honestly think that much of the work that recovery coaches do, and Will had mentioned this earlier, is in the harm reduction arena, because the community at large is always at risk of a person picking up again, right? So in a traditional treatment program, you have this protected environment, and the work really starts when the person leaves. So I think the field is going to move more towards a chronic disease model by providing more community-based care with recovery coaches. And even though there's a curriculum that Jim Wolfing put together called harm reduction in a recovery coaching, in a harm reduction environment, I would challenge the fact that if you're working out in the community, you're always working in a community where harm reduction has to be part of your repertoire and strategies, because it would be rare that everyone you're working with is abstinent or is interested in abstinence when they're coming in and when they're engaging and working with you. So you always need to be able to see in terms of what are your strategies for people. We're always in the business of recovery, whether it's recovery management or relapse prevention or prevention on the front end. We're always in the business of being able to have everything in our toolbox to be able to help individuals. Next slide, Walter. So as I mentioned earlier, this is the CCAR list of multiple pathways of recovery. There are multiple pathways: 12-step recovery, religious recovery, secular recovery, medication-assisted treatment, wellness-based recovery, which is like yoga, meditation, active recovery community, fit for recovery. There's adventure recovery, Phoenix, multi-sports. All these are viable options for people. Online recovery in the rooms. Now everybody's doing it in a way where it's, you can actually get that support and that connection remotely. As long as you're connecting with people, feeling lovable, connected, and capable, that's in a sense kind of the measure of mental health in my mind. And harm reduction is a pathway to recovery that people have to recognize and put on this list. Next. So why is harm reduction so important? Let's look at the numbers. For every death that we have, it's the tip of the iceberg. There's only 10 people, 10 to 15% of individuals, and NIDA has done this work for years in tracking engagement and treatment. Only 10 to 15% of individuals who actually have a substance use disorder and could qualify for treatment seek treatment out in any given year. So you've got one person who's died, you've got 10 people who are actually coming into traditional treatment. But meanwhile, 32 people are coming to emergency rooms that are coming there oftentimes in the consequences of their use and misuse. And that's why we in Connecticut started this great strategy of having emergency department recovery coaches to help engage people. And it was one of the best connections and engagements that I've seen in my 30 years of my career. In the first 4 hospitals in Connecticut, out of 610 people, where all they asked was, would you like a recovery coach? And the recovery coach asking that person, how can I help you in your recovery today? Out of 610 people, they got 604 people into recovery. Phenomenal engagement rates because they're meeting where they're at without an agenda. So there's still, out of that one person that dies, the 10 people in treatment, the 32 that are struggling and coming into an emergency room, 130 people are out there still in the throes of addiction that are still using, that we're not engaging in our treatment system, because harm reduction is innovative engagement. And for the most part, as an industry, we have not across the board standardized this innovative engagement that could save many more lives and convert that need for treatment into demand for treatment to become more attractive and appetizing for individuals. One of the best programs that I've been able to work with over the years is our Ryan White program. So our Ryan White HIV program does not require abstinence to participate in that program. If a person is HIV positive, they have a Ryan White worker that stays with them for life, regardless of their motivation to come off of drugs or not. And what's amazing about that program is that engagement, that compassionate engagement, that ability to give a person what they need to help them with their medication, with their oftentimes legal situations or childcare, or get a job and just get on track in life. By doing that and building a relationship over time, we've seen a majority of those individuals say 2 years down the line, 3 years down the line, sometimes 5 years down the line, okay, I'm ready now, John, sign me up for treatment. I'm sick and tired of being sick and tired or whatever. And then they become connected, right? Somebody's talking about enablers. Let me get at that later. I got a slide for that. And you have 825 non-medical users. By the way, the jury's still out on how many people actually need to be in treatment and traditional recovery and how many people just need a brief intervention. We know this in the alcohol field. It's substance use disorder, mild, moderate, and severe. And those mild substance users, regardless of their drug of choice, can get on track again and perhaps develop a relationship that isn't going to get them in the throes of addiction with their substances. And that's a majority of the people out there using. Next slide. we talk about the criminal justice system. If we're looking at engagement, this is an amazing opportunity. My pitch for engagement is, and particularly with all that's going on in the country, and everyone's talking about social justice and the police brutality, our system is ripe to change. And some of the racial inequities that we're seeing on the front end are racial inequities that go through the whole criminal justice system. In Connecticut, there is an overrepresentation of people of color in our Department of Corrections and throughout the whole country. And part of where we could really intervene is not just in educating law enforcement, which is great. I would love to see a law enforcement assisted diversion program in every community, the LEAD program such as Seattle, Washington. But there are other programs. In Connecticut, we're doing now a pre-prosecutorial diversion program where the special prosecutor comes to the courts, looks at substance abuse cases, and will divert them out on the front end. This is fantastic because if their person's successful and gets diverted from the prosecutor's office, they won't get charged. So on top of all their issues going on in life for recovery, they won't end up with a criminal record. And then, of course, we know there's the treatment pathway program that we had in Connecticut too, in the bail commissioner's office to assess people pre-arrangement diversion. And you have the drug courts, you have treatment programs in the institutions, and oftentimes we don't have much engagement in reentry. So in Connecticut, we're starting to assign people recovery coaches before they come out at that time when they're most vulnerable to re-enter as citizens in the community and give them the supports they need because they're at incredible risk of overdose when they come out. So here is a different levels of intervention. People know all the key players. You've watched enough Law and Order to figure that one out. And these are the intervention opportunities on the bottom. So I would really challenge you in New York to be able to look at having those interventions partner public safety with public health interventions to work together to be smart on crime. Next. Next slide. We're gonna have to do a puppet show soon, Walter, if we don't get the next slide up. They coming?
Just a moment.
Okay. Somebody talked about enabling. Don't get me started on language. Enabling is such a load of crap, if I may speak clinically. Enabling is just showing love the best way you know how in that moment. And our goal in our work in our treatment program is to redefine relationships in a manner that promotes recovery and promotes health. It's never enabling to keep somebody alive. So that's where harm reduction is really confusing to people. People are like, oh, you're enabling the person to use. No, you can't find recovery if you die. It keeps people alive. And we have to stop being so arrogant to think that we know what's best for individuals. What we have to look at is perhaps 2020 may not be the year of recovery for individuals. My agency, our kind of tagline is recovery for life, and we stand for hope. Next slide. So one of the initiatives in our agency is we try to give people something of value. So we give them acupuncture, we have a dental and a medical care on site. We have a mobile wellness van that's wrapped up like a psychedelic called Peace, Love, and Liberation, which is very non-threatening and engaging. And on that van, we have a waivered professional that can provide buprenorphine. We have syringe exchange, and we have a recovery coach to meet people in the community where they are. We give overdose kits out that include crack pipes because that actually will reduce harm for people, and we'll meet people where they are, no matter where they are. We also have a food pantry because we can't ask people questions when they come in on their clinical biopsychosocial. You got to start with asking them, when was their last meal? Are they hungry? Do they have safe and supportive housing? These are the important questions. We even have a mobile market on site. Next, Walter. I mentioned stigma matters. So, stigma matters, language matters to reduce stigma. We actually contribute to the stigma, some of the ways that we speak about things. So what we want to look at is seeing addiction not as a moral issue, but as a disease. And the heart are the best category. Addiction is a health condition. We see recovery as an expectation impossible for everybody. And we actually call individuals recoveries, not clients, not a person in recovery, but recoveries, and recognize there are multiple pathways to recovery. Next. So this is what I just said, enabling. Everyone shows love the best way they know how. Keeping people alive is not enabling. Harm reduction is not enabling. It's enabling people to stay alive and engaging them. As I said, 2020 is not the year of recovery. Click again, there's one more thing on that slide. And if we work with families, we help realign their relationship in a manner that promotes recovery for every family member. And we recognize that family members' recovery is independent of their loved one. Next slide. Again, harm reduction is treating people with dignity and respect without our agenda. Next slide. I think it might be the last slide. Oh yeah, this is speaking of dignity and respect in a recovery environment. Here's what we just opened last year. This is our methadone program. How cool is that? Beautiful building, right? This is what people deserve to walk into and not add to the stigma by some clinics who really don't look like they're really treating people with a recovery environment with dignity and respect. So that's one of our methadone programs. So if you meet clients where they are, you'll always walk away with love, new understanding, and compassion. If you walk away frustrated, if you walk away angry, if you walk away upset, it's always your issue. It's time for supervision. Last slide. So I want to end with just saying that, again, at the end of the day, it's more important to show people how much you care before you show them how much you know. Because at the end of the day, we don't know much of what works for people, but we can certainly show them love and show them how much we care. Thank you. That's my presentation for today. Hope it was helpful. Any questions? I think there's a lot of questions, huh? What do we
John,
got, Walter?
if you could see the chat, then you could just take over and answer any questions that might pop up.
All right.
All right.
Anybody got questions? All right, let's see what we got. Okay, really good. Somebody addressed the challenges of having to be socially distant. Out in the community, that is a challenge. Yes, everyone's wearing masks. Everyone is following social distancing. We've been very careful. Our groups are only 5 or less in our Connecticut executive order and mandate. We, as mentioned before by Tricia, have given all our stable individuals up to 28-day methadone in our program for take-homes, less than stable 14, and unstable, we try to give people daily to keep them engaged in the system. Everybody else just kind of like the presentation. That's a good sign.
It's not a bad thing, right, John?
Yeah, yeah.
All right. Well, thank you very much, John. That was fantastic. Very, very nicely done. So,
Walter, there is one more question just popped in the chat just now
oh, good. Okay.
from Carter Martin.
All right, John, do you see it?
Okay. Yes. The question is, what do you recommend for family members of recovery in order to support them and deal with their own issues of trauma? Again, that's a great question, because what we do is we see family involvement as the expectation of treatment. So right when somebody wants to come in for treatment, we ask them who participate with their recovery, who's going to be participating in the recovery and driving them to treatment. So we'll engage anybody, faith community, a sponsor, somebody on the streets that's bringing them in, anyone. We expand our definition of family to anyone who's committed to their recovery, but we immediately give education to family to have them not have to follow every lead to try to get their loved one sober, which is nothing short of manipulation when you think about it, but have that understanding that their recovery is independent and that the greatest gift they can give their loved one is to role model their own recovery process. So if they want their person to go to self-help support, they also need to show that if it's good enough for them, it's good enough for their loved one, it's good enough for them, and to model mutual support for family members. That's just one example. But that's the key, is to have them be able to understand how difficult it might be for their loved one, have some empathy. In my work in private practice, I'll always have the individual see if they could be sober for 90 days, just to show how much of a struggle it might be. Even if alcohol wasn't an issue for them, just to have some skin in the game, to be able to show some support and have some connection, and also to have them recognize that their process and their recovery is completely independent. And relapse for them, maybe, questioning certain things and doing too much of the work or being suspect. So they need to get the support so they can actually help their loved one. Because if their loved one is doing all the work in isolation, and they're not doing their work, they may sabotage without even realizing how to support that person's recovery.
Okay. John, I think we covered it. And again, thank you so much for coming on today, John. That was fantastic. I'm sure everybody felt that it was very informative and engaging, and certainly topical, which is important as anything. So,
Walter, there is one more question in the chat if you want to grab one
oh,
more.
good. All right. John, do you see it?
From Trisha Shell.
Okay.
Oh, yeah.
Shell guy.
Well, yeah, this is a great question, Tricia. Basically, it's more of a comment that New York's struggling with federal rules that do not allow purchasing fentanyl strips. I have thoughts on that, and there is this. There are different regulations, and just only like it was only 5 years ago when Mike Botticelli was running ONDCP that they actually released the ability to have syringe exchange materials purchased by the federal government. So the federal government do have restrictions around fentanyl strips, but your city health departments don't. So
Right.
each city health department may be where you want to contract services. So even in our van that we received SOARS dollars, that the state opiate response dollars to fund that van, we had to have a separate grant in the van to be able to provide some of the needle exchange program, because it would have been in conflict with the federal funding for the recovery coach. So you have to look at being able to be innovative with a blended funding model to be able to get much of these services funded.
Yeah, thank you for that. So at the state level, SOR funding is something that we really want to be able to use for innovation. We had the idea and have been asked multiple times to supply fentanyl strips, and have asked multiple times at the federal level, if there's a way for us to do this. We do have state dollars, right, that we could use, and I've opined with my commissioner we could use that. One of the things that we're thinking of doing is creating an emergency kit that would include a fentanyl strip, a Narcan kit, a mask, maybe a condom, maybe even a syringe, and distributing it to those who need it most. We're struggling a little internally too with, we want everybody to have Narcan. We've put it out there, but we also want to make sure that these go to the folks who need it most. And so ideas on how we would distribute those emergency kits, if we could do it, to who needs it most would be welcomed.
Okay. All right. So it looks like that we did cover all the questions, and unless anyone has anything else, we'll check the chat one last time. And otherwise, thank you again, John, so much. That was fantastic.
My pleasure.
Very engaged. So we wanted to play this message now by our sponsor, Capelli Group. So if you could just bear with us, we'll present it now.
Good morning, everyone. My name is Corinne Perry, and I'm speaking on behalf of the Capelli organization today. We have deep roots here in Westchester County, so it is truly an honor to be associated with an organization that has such a positive impact on our community. I would also like to take a moment to thank everyone at NCIDD for welcoming me to the board and inviting me to say a few words today. It really speaks to the hard work of the organization that even amidst the endless challenges of the ongoing pandemic, they are still able to continue making a difference in people's lives. Their ability to pivot quickly and still bring people together virtually is so important. So on behalf of Capelli, thank you to NCIDD, and thank you to everyone for joining us today. We hope you are all staying safe and healthy. We know this is a challenging time, but we must all do what we can to help each other get through this together. Thank you. Good morning, everyone. My name is Corinne Perry, and I'm speaking on behalf of the Capelli organization today. We have deep roots here in Westchester.
Just X out of the
It's
video.
truly an honor to be associated with an.
Okay. So at this point, as we close the conference, we just wanted to turn it back over to Joan for some final thoughts and comments. Joan? Oh.
Joan, you have to unmute yourself. You are muted. Walter, can you unmute her from your side as the host?
Clicking, it's not.
Thank you.
on. Yeah. All right, so Joan looks like she's not able to.
Here she is. She's good. There she is.
goes now.
I'm good now?
Yes, you are.
Here we go.
Okay. Thank you again, everyone. This was a marvelous morning, so informative and uplifting. Especially at a time like this, we all need to know that there are many ways of being proactive and helpful. From our sponsors, who I believe have given a marvelous message. Started with Natasha, since the video for Corinne came at the end. But Natasha and Will, terrific, just terrific message. Tricia, yes, I really enjoyed listening to where Oasis is at today, because I've been around to watch the evolution, and it has been quite a journey. And John, amazing as always. Corinne, thank you for your absolutely magnificent words and sentiment about who we are in Westchester. We need all the love and support and motivation that we can get, and encouragement, of course. Everyone is working very diligently, and we are at a crossroads, I believe, in all the services that we are offering, hoping to expand. When I hear about recovery rooms, etc., there's so much to do. And with everyone's understanding and help, we can move along and be proactive and be ahead of the bar. So thank you again. And I believe we'll be doing more conferences in the not too distant future, sooner than later in person. But in the meantime, this is a marvelous way of connecting and being where we are, not necessarily where we want to be. Is that how to do harm reduction, right? I've had to learn harm reduction in my own life here. How do you manage your life on a different level? Not easy, but it's a learning curve. So even at my stage of life, there's always something new to learn. For you who are participating today, I hope there's a great takeaway. You had good information prior about harm reduction, wonderful. If not, I hope you really and truly understand why it is a powerful modality. Thank you again to everyone, Walter for hosting, I should say for emceeing this. Great job. And to everyone, see you very soon. And we will be sending out notices for our town hall, which will be on July 9th at 7 in the evening. We'll let you sleep that day. Thank you again. I turn it back to Walter.
Thanks so much, everyone. And just so you know, we will be posting a recording of today's webinar on the NCADD Westchester website, providing a link on the social media, which continues to grow. And we'll get back to you again on anyone that needs a copy of any of the individual presentations. So again, on behalf of NCADD Westchester and Joan and everyone, thanks for joining us. Have a great weekend, very uplifting, and we'll see you next time.
All right.
Thanks,
Thanks,
everyone.
everybody.
Thank you.
Have
Thank
a great
you.
weekend.
Thank you, Joan.
Thank you. Thank you. Thank
So
you.
much for doing this.
Thank you, John.
Take care.
Thanks,
Thanks.
Natasha.
Great job, Walter. Thank you.
Thank you.
Thanks,
That
Joe.
was great. Thanks so much. Bye-bye.